address here is we're going to test we already tested the rectus femoris, and we want to treat that. Okay, so at the ASIS, just inferior to that, okay, that's where we want to start for the rectus femoris. So we're going to have the patient, we're going to start in this position, and then we're going to tell them take a deep breath in through their nose, breathe out through their mouth, and they're going to drop the foot onto the table. This is a 6-second procedure. So we'll come in here, let's take a deep breath in, breathe out, and I'm just leaning into her leg. 2, 3, 4, 5, 6. Good. Deep breath in for me, breathe out, and go. 1, 3, 4, 5, 6. And again. Good. All right. Now that's going to be our rectus femoris. Now she was also weak in the iliacus. So the ASIS is actually going to be our landmark. So if this is our ASIS, and for those of you who actually attend my seminar in my clinic, I actually have a 3-dimensional model of the lower extremities, the hip. So you can see at the ASIS, let's just say this is the ASIS, if we take our thumb and we put the bend of our thumb on the ASIS, you will actually be right on the iliacus. So again, we tested the rectus femoris in this position. All right, the iliacus with the foot turned out, and then the psoas 30 degrees up, 30 degrees out, and the angle of the foot is at 45 degrees. So the next thing we want to do is treat the iliacus. So what we're going to do here is we're going to turn the foot in here, and this is why it's important to look at agonist-antagonist relationship, because if I come in here and treat her rectus femoris, the iliacus, and the psoas, in just a second, we're going to go over these muscle groups that are short, and her glute max is too short because her foot should actually be right here. Okay. And that one's your bad one that hurts. Okay. Prime example of why you don't look at the blinky light. Her left hip hurts, but look at this. Okay. And her left hip hurts, but look at this. The mechanics of her glute max is fine. Isn't that amazing? Don't look at the blinky light. All right, so we got to fix her glute max, and we'll talk about that in just a minute. But try not to run too many rabbits down the hole here. So rectus femoris here, hold for me, hold. Just keep your legs straight. We checked it, we worked on that. Then we checked on the iliacus. All you have to do is 30 degrees, foot out at 45 degrees, hold. Hold that up for me. Okay, so here's how you're going to treat this. We have the ASIS. We're going to take our thumb, put it right on the ASIS, and the tip of your thumb will be right on the iliacus. So relax your leg for me. Just bend it right here. All right, and then what I want you to do is take a deep breath in for me, breathe out, and pull your leg down into this position right here. 6 seconds. Deep breath in, breathe out, and go. 4, 5, 6. Deep breath in for me, breathe out, and go. And deep breath in for me, breathe out, and go. Okay, and now her psoas was also weak as well, so we got to activate the muscle spindles. So here's the ASIS again. Remember, inferior to it, rectus femoris. Medial to it is the iliacus, and then if we actually put our thenar on the ASIS, will be right on the psoas. So palpate the ASIS, thenar. Here we go, we're right on the psoas. This time what I want her to do, bring your foot out 30 degrees and go down. All right, deep breath in for me. Breathe out, turn it off, turn it out 30 degrees and pull down for me. All right, one thing I would recommend that you not do is this right here. Okay, here, and don't bend your back. Don't do that. Okay, you can actually use your right here. All right, deep breath in for me. Breathe out and go. 2, 3, 4, 5, 6. If you use your arms, it's going to save you a lot of backache and a lot of back pain, and so just use your arm and try not to bend over so much. So what we went over was the test for the muscle spindle activation for strength of the rectus femoris, iliacus, and psoas. That is short. So the patient will sit on, and then we'll lay back for me. And when we lay back, what we're going to do is we're going to be bringing this right knee to their chest. But what we're going to be doing is testing this left psoas. So what we'll do is in this position here, and if the psoas is short, then this knee will come off the table at some level. All right, let's go to this side here just to see what happens. And it's all good. But what I want us to do is if you could go up and lean, go to this side of the table. All right, so what we're going to do with this is if the patient is short in that position, let's go ahead and drop that down for me. All right, so what we're going to do is trap the leg here with my leg. We're going to come in here on the psoas. Remember, we're going to take the ASIS and the psoas, ASIS and the thenar here. We're on the psoas. And I want you to take a deep breath in for me and then pick your knee up and kick it up toward the ceiling. 2, 3, 4, 5, 6, 7, 8, 9, 10. Good. All right, let's do that again. Deep breath in for me, breathe out, push up. And again, that's good. All right, so I don't want to push her in that position because simply she does not have, that's not an issue that she has. So the next thing that we're going to do, kind of center on the table right here for me. All right, and then we want to test the length of the adductors of the leg. So we want to come out, and as long as they're at 45 degrees or greater, they're fine. There, drop that over there. All right, let's just drop that leg down right there. The reason we want to drop that leg down is because when we do the Hoffman's test on the adductors to see if they're short or not, when we actually start to do the Hoffman's test, we don't drop the leg down on the side, it's going to spin her around. So we're just going to do one of these. I want you to take a deep breath in, breathe out, bring your leg in like that for me. All right. So right here on their pants, there's a seam right here, and that's exactly where you want to be. So let's take a deep breath in, breathe out, and bring your leg in. 2, 4, 5, 7, 8, 9, 10. Relax. And again, if you don't have this leg over the table, as soon as you do the Hoffman's reflex, you're going to swing the patient off the table, hence no Hoffman's reflex. So in this test, we tested the psoas muscle, we did a test treatment, and of course you want to retest if there was a positive finding. And we also tested the adductors muscle to see if they were short. We lengthened them, we activated the golgi tendon organ, test, treat, and retest. All right, so the next muscle group after the glute max is we're going to test the piriformis. So what we want to do with the piriformis is bring the foot across the body, because the piriformis is a rotator of the hip. We're going to do 90 degrees, and I'm going to bring your foot out like this for me, okay? So I need you to hold it in. So take it, hold for me, hold. Okay, so what we would do in this position is I would tell the patient what I want you to remember. The test position is the start position. So if this is weak, this is going to be the start position. We come in here with a rapid release onto the piriformis and tell the patient to rotate their foot out. So let's take a deep breath in for me, breathe out, and rotate your foot out. Good, and we'll do that 3 times. And again, good deal. All right, and then we can come back in, test, treat, and retest. And that would be our piriformis. All right, so again, the patient is prone. We're going to be testing for the length of the muscle groups, and we came in and we said here, rectus femoris. Ideally, we would want to see the heels 2 inches from the hip. All right, we've gone over how to treat that. The piriformis, the legs here need to be at least 45 degrees. All right, the next thing we're going to do is test the glute medius and minimus. We're going to bring the foot in. All right, now we can see here that that's a problem because you can see how our hips come off the table right there. All right, hopefully this one will be good. And it's not as bad, but it's not as good as this one right here, or bad that one. You can see how the hips are coming off, because what should happen is the hips should just rotate in the joint. We shouldn't be pulling the hip off the table. And I will tell you, from me and from my standpoint, This is one of the harder muscles to actually correct from a Golgi tendon organ standpoint. So what we want to do is we're going to take a deep breath in, we're going to breathe out, and I want you to rotate the foot out in this position. Now in the clinic, the way I do this is I actually stand on this side of the table with the rapid release in the hip area right on the glute medius and minimus, but for the camera's sake, I'm going to stand on this side and just assume that I have a rapid release here, because you can see how that's going to negatively impact my back, bending over a patient like that multiple times throughout the day. So I want you to take a deep breath in for me, breathe out, and rotate your foot out for me like that. Deep breath in, breathe out, and go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. All right, and let's take a deep breath in for me again. Deep breath in and out. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And again for me, deep breath in, breathe out, and push out for me. 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay. All right, let's see if we, and again, just telling you that this is the hardest muscle for me to actually fix from a Golgi tendon organ standpoint in the clinic. Let's see what happens here. And you can see how she's still coming off the table like that. All right. In the clinic, this is exactly how I would do it. I'm on the same side as the bad hip of the glute medius and minimus, and she needs a little help here. So let's take a deep breath in, breathe out, rotate your foot out for me. 2, 3. And relax. Deep breath in for me, breathe out, and go. 8. All right, and one more time. Deep breath in for me, breathe out, and go. 2, 3, 4, 5, 6, 7, 8, 9, 10. And it's been a while since I've used my thumb so much, and I can tell you I wouldn't want to do that every day with every patient. So that would be our glute medius and minimus. So again, with the prone position to test for the length, we go right into the hamstring, and then once we're in the hamstring position, we want to test for the glute max, and then see we have that glute max that's short. So what we should have here is this foot should be in this position. All right. And then we look at this one, and we still have a little bit of a rotation problem with this foot, all right, but the actual hip flexion itself is fine. So the way we would, then you got both hips that need a little bit of work. So come over toward me just a little bit. All right, good. All right, so when we do this, we want to actually trap this leg here from going up, because if we're standing out here, what will happen is this leg actually comes off the table. So we want to, I'm going to take my body and trap this leg to keep it from coming up. And then what I want the patient to do is I want the patient to take a deep breath in through their nose, breathe out through their mouth, and go into this position with their leg. And of course we want to do, since we're dealing with Golgi tendon organs, we want them to do 80 to 90% maximum exertion. We're not going to let them move the body part, and then when we do our Hoffman's reflex, we're actually going to rotate our body like that. Now in the clinic, I'm going to use a rapid release right on our glute max. So if you don't have that, you can use your knuckle, or you can use your forearm like that. So let's take a deep breath in for me, breathe out, and bring the foot down and out. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and relax. All right. Remember, whatever the Hoffman's reflex is, that's the new start position. Now, sometimes there will be a little bit of moaning and groaning here as well, because this can be a tough muscle to activate. All right, deep breath in, breathe out, and go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Hoffman's reflex. All right. So let's see how this is right here. All right. Here we go. All right, now this one here, we've got And again, this is probably not going to be 100% corrected in one visit with this rotational component, but we do need to get this foot as close to this 90 degrees here as we can. So again, pretty doggone good, okay. Needs a little bit of work. Okay, let's scoot all the way over to that side over there for me. All right. So again, don't forget that when we do this, slide over just a little bit more for me, all the way to the edge. Okay. The reason we need them at the edge of the table is because I got to block this leg. Okay. I got to block it with my leg. All right. Now on this one, her hip flexion is pretty good. It's the rotational component that's not so good. So I want you to focus more on rotation than anything else. Kind of bringing your foot out like that. Okay. All right. So let's take a deep breath in for me. Breathe out and rotate it out. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and relax. All right, deep breath in for me. Breathe out and go. 1, 3, 4, 6, 7, 8, 9, 10, and last one. And one more time, deep breath in, breathe out and go. 2, 3, 4, 5, 6, 7, 8, 9, 10. All right, so let's look at that. You can tell how much fun she had. All right, so, that's where we were, and we're going to have to work on that. The rotational compartment of the hip is harder to fix than the actual flexion aspect of it to get it to lengthen. But from where we were to where we are now is a little bit better. Let's do that one more time and let's see what we can get out of that. I know Tony's really looking forward to that, but really work on that rotational compartment, swinging that leg out. All right, deep breath in, breathe out and go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. All right, and let's do that again. Deep breath in, breathe out and go. 2, 3, 5, 6, 7, 8, 9, 10. Last one. All right, let's push, deep breath in, breathe out and push as hard as you can. Come on. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. There we go. That's usually what you're going to hear, some, oh my God, this is, but that's what it's going to take to, I tell patients a lot that if we stop when it starts hurting, it's like going to the gym, and when you start kind of gritting your teeth, it's like it's just, you got to really push it. All right, so here we go. All right, the hip flexion component is still there, but all right, in this position, let me just give you an example. What I would do with Tony is say, when we do this, her right foot, all right, on the couch, on the bed, or whatever, one of the stretches that we can do at home is we want to go into this position, all right, bend your knee, all right, and lean forward. And that's what we would need to do, okay? Mm-hmm. So if you look at where my knee is here and this bending forward, this is the actual stretch that she would need to do to actually stretch that glute max from a rotational component, okay? Mm-hmm. All right, so that would be our glute max test for gold tendon organ length test, treat, and retest. The closer you get to the knee, the more pain the patient is going to experience because. All right, so we're going to recap quickly. So we got our rectus femoris, and we're going to hold that, iliacus, okay, and then psoas. I just went over how to treat that. And today we want to talk about the neural reconnect systems, low back, hip, knee, and foot. One of the things that I would like to really go over quickly is when we're dealing with any of the lower extremities, we want to make sure that we look at the neurokinetic chain. So, like, we're all doctors here, but just to reiterate, we have 5 lumbar vertebrae, 5 nerves that come out. L5, the reason we want to look at this is because if somebody comes in with hip pain, we want to look at the lumbar spine because L5 mainly fires and innervates the muscles to the hip, like the glute medius, minimus, tensor fasciolata, glute max. All right, L2, 3, and 4 make up the femoral nerve, and that nerve controls the muscles in the front part of the knee, or the anterior aspect of the knee. L5 controls the popliteus, and that's a major player in the muscles in the back part of the knee. And then also, if we're suffering from plantar fasciitis or peripheral neuropathy, we want to look at L5 to see if there's any damage at L5 and address that. So we want to treat the spine, we want to treat the end organ, and then also we may have to, in most situations, treat the patient metabolically and do a gut detox and a whole system to actually optimize the recovery of the patient. But the key point here is, whatever the end organ symptom is, we want to look at the neurokinetic chain, meaning we want to go back to the spine and work our way down the neurokinetic chain to optimize the recovery of the patient. All right, so let's just kind of do a quick recap, and then we're going to just keep moving forward. So, patient comes in, and we've got low back, hip, knee, foot, whatever problem. We come in here, do a bilateral test, and here we go. We've got the rectus femoris, okay? We've got the iliacus, we've got the psoas, and then we come to the foot of the table here, tensor fasciolata, this foot's going here, hold, all right? And then all we have to do is turn the foot straight up, and then hold, glute minimus, and then glute medius, hold, all right? And then the next thing that we're going to do is I want to test, bring that right there. Now we have the lower head of the rectus femoris. So remember, the rectus femoris is the hip flexor and the knee extensor, so we have to actually test that. So let's hold this right here for me, hold, good. And then we're going to test the vastus medialis. All right, so the heel, the foot is out, heel is in. The heel is actually pointed toward the muscle that you're actually testing, the vastus medialis. Hold, vastus lateralis, the heel goes out. So wherever the heel is, that's the muscle you're testing. Hold, good. All right, now when these muscles are weak, in this situation, I'm going to show you how to treat each muscle individually, then I'm going to show you how to treat the vastus medialis and lateralis simultaneously. All right, so the first thing I'm going to tell the patient is take a deep breath in through your nose, breathe out through your mouth, and then we're going to, when we breathe out through our mouth, what I want you to do is take your heel and pull it toward your butt for me, okay? So we're going to engage the rectus femoris. So remember, origin and insertion, the muscle spindles are in the same parallel plane as the muscle fibers. So we want to actually distort those muscle spindles. So we want to do a parallel type of manipulation on these muscle spindles. So let's take a deep breath in for me, breathe out. Oh, let me back up just a second. Because I do this so much, you actually forget sometimes how to break this down. So Tony can tell you that what I have here is I've got her heel in the area of my hip. I'm actually distracting her back here. All right, and then whenever we activate this, what I want her to do is take the heel of her foot, pull it toward her butt. Now, if patients do this wrong, what you'll do is you'll actually start skipping forward, and that's not what you want to do. What we should do is my left leg, which is on the table, all I should do is this right here. That's all that should happen, and I'll do it on the opposite side of the table as well. So let's take a deep breath in for me, pull down for me. 3, 4, 5, 6. Deep breath in for me, breathe out and pull down. Good. And again for me. All right, so that's the rectus femoris, and I'll show you again on the other side. Vastus medialis. I'm going to turn the foot out, heel in. We're going to come in here just proximal to the knee joint, and then what I want you to do is take a deep breath in, breathe out, and pull your heel towards your butt again for me. All right, deep breath in, breathe out, and go. 2, 3, 6. Deep breath in for me, breathe out. Okay, and again for me. So we can treat these muscles individually. And then again, I'm going to show you in just a minute how to treat the vastus medialis and lateralis at the same time. Here, we got the foot turned in, going to the vastus lateralis, deep breath in, breathe out, pull your heel toward your butt for me. Good. And again for me. And again. All right, so let's go on this side over here. Go ahead and slide over on this side for me. So what we're going to do this time is just maybe give you a little bit better angle from the camera. But again, I've got her foot in my hip right here, going back, distracting, but you can tell I'm distracting it down. We're going to take a deep breath in for me, breathe out, pull your heel to your butt. All right, deep breath in, breathe out, pull down. And again. Now, what I do in the clinic is when I'm working on someone's knee, the rectus femoris is a big player in this. But what I'm also going to do is I'm going to hit the vastus medialis and lateralis at the same time. So all we have to do is keep doing the same procedure. I've just got to activate two different muscles. Deep breath. This is somewhat painful, uncomfortable, let's just say that, with a patient who has knee problems. Deep breath in, breathe out, and go. And you can tell how much fun she's having there, and pull down. And again. So she doesn't have any knee problems until she wasn't liking that a whole lot, were you? So a little bit uncomfortable. So here, what we just did here, we did rectus femoris, vastus medialis, and vastus lateralis. All right, we wanted to go through the knee protocol. Now again, when we're dealing with the knee, the hip, the foot, we always have to look at the lumbar spine because we have to address the neurokinetic chain. Meaning, in the lumbar spine, we got to test the multifidus to see if it's short. We have to test the QL to see if it's short, and also the QL to see if it's weak. All of that has to be addressed to optimize the recovery of patients suffering with lower extremity issues. One of the things that I do is I use this actual laser here for the knee pain program. After I turn the laser on, you will actually see the little lights blinking right here. You'll love that because I talk about the blinky lights under them all the time, and then now we got a blinky light. All right, so what we're going to do in this situation is for 10 seconds, okay, we're at 6 o'clock and 12 o'clock, or 12 o'clock and 6 o'clock, any way you want to look at it. All right, so we're just going to go around the clock, if you will. So 12 o'clock, 6 o'clock, 10 seconds. Then we're going to go 1 o'clock, 7 o'clock. All right, 10 seconds, and then 2 o'clock, and then 8 o'clock. And we're going to do that for 10 seconds. Then we're going to go 3 o'clock, and then, 9 o'clock. And then we'll come over here and we'll do 4 o'clock and 10 o'clock. Then we'll do 5 o'clock and 11 o'clock. And we finish that whole, we just hit that entire knee here. Now, another thing that we're going to do, and I'll do my best to stay out of the way here so you can see this, but we're going to come in here. Remember what I said about the pes anterior being a big time player in the knee. So we're going to come in here with this laser, and we're going to hit the pes anterior. I'm going to give it a 10-second laser shot here. And then while I'm on this side, what I'm going to do is say, take a deep breath in for me, breathe out, and kick your leg out. Okay, we're going to do that 3 times. We're going to do that 3 times. Okay, so now we've got the muscle groups and the tendons warmed up here. So what I'm going to do for this is the knee pain protocol. I'm going to come into the inferior patella tendon. I'm going to tell the patient to take a deep breath in through their nose, breathe out through their mouth, pull your heel toward your butt. So let's take a deep breath in, breathe out, pull down. 3, 6. Deep breath in for me, breathe out. And again for me. All right, so we got the infrapatellar tendon. And I'm going to hit the infrapatellar tendon and suprapatellar tendon at the same time. Pull down for me. Deep breath in and breathe out. I hit those 3 times, then we go right up the rectus femoris. Usually the rectus femoris is not that painful most of the time. The infrapatellar tendon, the suprapatellar tendon can be, and then when we get on the vastus medialis and the lateralis, it usually is. All right, and then we're going to have the patient flip over on their belly. And the reason I keep the laser going here is I hit the laser here on the popliteus, 30 seconds, 10 seconds here. If you don't have the laser, don't worry about it. I have the laser, so I capitalize on it. And then we're just going to come in, 10 seconds. Okay, I thought, yeah, at the end of each cycle, it'll stop for just a couple of seconds. All right, and then now what I'm going to do is take this laser. I've got 2 lasers here. We're going to bring the foot, the leg at a 90-degree angle. We're going to come right in here on the popliteus. We're going to take a deep breath in for me. Breathe out, push your foot down, and turn it out. So right where we're on the popliteus, deep breath in, breathe out, push down, and turn out. I'm going to lay this to the side right here, and we're going to deep breath in, breathe out, push down, and turn out. And last one. All right, so that would be my, that's going to be my knee pain protocol for the patient, and I hope you enjoyed the video. All right, so the next muscle group after the hamstrings is we're going to test for strength. We're going to test the popliteus. So what we're going to do with the popliteus is we're going to turn put the knee at a 90-degree angle, turn the foot in at a 45-degree angle, and then we're going to scissor into this position here. All right, so what I want the patient to do, Tony, if you would, just keep your foot turned in right here and hold, and that's the actual that's a strong muscle. So with the popliteus, now please understand, when this muscle is weak or it's short, this is a very, very painful muscle to actually treat. So just be aware of that. And I tell patients when I treat this, it's like, this is going to hurt. There's just no way around it. This is again, you'll experience this in your clinic. I'm just giving you a heads up that this muscle is going to hurt. So we're going to take I'm going to be generous today though. So, all right, so we're going to put the foot in this 90-degree angle. This is the test position. All right, that's the start position if it's weak. The popliteus, it goes from the lateral side of the femur to the medial aspect of the tibia at a 45-degree angle. Now we're going to come in here with our thumb. We're going to take a deep breath in, breathe out, push your foot down, and turn your foot out. Okay, deep breath in for me, breathe out. All right, and here, this is just a guide hand. This is a resistant hand. I'm resisting and turn out. Okay, so that would be our popliteus for the knee. And again, this gets a direct feed from L5. So if you've got an L5 damage in the lumbar spine, this could cause knee problems because of the popliteus. Another thing that's important with the popliteus is when it's weak, this muscle is actually the key that unlocks the knee. So when it's weak because of a possible L5 problem, the femur has a tendency to want to shear onto the tibia whenever when we're taking a step. And over time, what will happen is a patient will come in and say, in the front of my knee down here at the bottom, it actually hurts. So you've got the inferior patella tendon can actually be going through inflammation or pain, and the problem is actually in the popliteus in the back part of the knee. So just keep that in mind. All right, so what we're going to go into next is the sartorius and the adductors of the leg, but I want to recap the flow of everything that we've done so far and then just add the sartorius and the adductors to it. So when we come in, of course, we'd want to look at the multifidus, right and left, the QL right and left to see if the QL is short or weak, and fix what you find. Then we come down here to the hip, and then we're going to test the rectus femoris, hold, and then the iliacus. All we have to do is just turn the foot out, hold, and then we take it out to a 30-degree angle, hold, and then that's the psoas. All right, and then we're going to turn the foot in. We come down here, tensor fasciae lata. We're going to take this foot, push it down to the other foot, turn the toe straight up, glute minimus, hold, and then we're going to take the foot down to the bed, and that's the glute med or medius, hold. All right, and then we're going to treat what we find. Then we're going to bring this leg up. Okay, and then we're going to test the rectus femoris for knee extension, hold. I'm going to turn the foot out. You can turn it in first, it doesn't matter. We just have to test both these muscles. Vastus medialis, vastus lateralis. Drop this leg down for me. And then we'll come in here. We want to adduct the leg, cross it over, and then we want to bend it. This is the position for the sartorius, and at the same time, we're going to test the pes anterine. So the pes anterine muscles include the sartorius, the gracilis, and the semitendinosus. So all of those are part of this, these three muscles that make up the pes anterine. So we'll just stabilize the muscle here, hold this foot right here in this position, and hold, here we go. Good, that one's actually strong. So what we do is we want to bring this foot out into this position. So when we do, if this muscle happens to be weak, for me, this is one of the players. I wouldn't say major players for knee, but it's definitely a player in the knee component when people have knee pain. We come in, and then we want to actually, our thumb is about 2 inches below the knee. The leg is crossed over, it's flexed and adducted, and we're going to have the patient, we're going to say, take a deep breath in for me, breathe out, and then we want to take the knee across the body here. So we want to extend it and abduct the knee, or the foot, I'm sorry. Deep breath in for me, breathe out, kick your leg out, and take it out to the side. Good. Deep breath in for me, breathe out, and kick. Okay, she doesn't have that weakness, so there's no point in me doing that 3 times. So sartorius, along with the pes anterine, we will take the legs over, past midline, and what we're going to do here is we're going to test the adductors of the right leg. So here, this is our 90-degree angle, hold for me. All right, and that muscle group is clearly weak. Now this is going to look a lot like the vastus medialis. So again, when we did the vastus medialis, we came in here. I'm holding the leg under my arm. Deep breath in, breathe out, bring your foot to your butt for me. That's the vastus medialis. Now, if the adductors are weak, we're going to have to bring the knee, frog leg it up to your shoulder, okay? And this can actually get pretty tender. All right, so puts out, deep breath in for me, breathe out, bring your knee up to your shoulder. 2, 3, 4, 5, 6. All right, deep breath in for me, breathe out and go. 1. In the clinic, I use the rapid release. Deep breath in for me, breathe out and go. And just realize that some patients with this, they can get some bruising in this area, especially with the rapid release. So in this video, we recap the muscle groups, and then we actually showed you how to treat the sartorius, the pes anterine, along with the adductors of the leg. All right, so now what we want to do is move into the foot. So these are areas, of course, that we're going to have to deal with foot pain, peripheral neuropathy, ankle pain, any aspect of foot abnormality. Please remember that we're going to have to deal with the neurokinetic chain, and then we also have to deal with the end organ when we're looking at this human being that's here with us, that's suffering with health issues, either low back and foot problems. But the way I do it again in my clinic, if a patient comes in suffering from any foot issue, my staff knows that we actually have to take x-rays of their lumbar spine and address the neurokinetic chain, along with any potential metabolic disorder this person has suffering with this foot problem. So there's going to be 4 moves that we're going to put the foot in. So if you'll think of this like an X, and so we're going to walk through each one of these muscle groups, and it is a group of muscles that sets this up. So when I'm at the foot of the table here, and then when we have the patient and we bring the foot up and in, okay, this up and in, we're actually going to be treating this tibialis anterior. Okay, so the up and in, so when we actually do this test to test for the strength of the muscle, we're also looking for the length. We're looking for the length of the tibialis anterior. We're looking for the length of the peroneus longus and peroneus brevis. So we have to think not just monomodal, but we have to think in a term of to cut down on time. When we put this foot up and in, we're testing for the strength of the tibialis anterior, so hold. All right, and we're also looking at the length of the peroneus longus and brevis, because, just relax this foot for me, if the peroneus longus and brevis was short on this side when we got ready to put the foot up in the test for the tibialis anterior, you could see the difference here. So we'd have to lengthen the peroneus longus and brevis. So we got the foot up and in, testing the tibialis anterior, hold. All right, hold, and again, the antagonist muscle group for this is the peroneus longus and brevis. So when we're treating this for the tibialis anterior, we're going to come in here and actually we're going to take this muscle group, and I'm going to say take a deep breath in for me, breathe out, and I want you to take your foot down and out for me. Deep breath in, breathe out, take your foot down and out. Good. Deep breath in for me, breathe out, down and out. And then again, down and out for me. So let's just recap here real quick. We're going to be making an X, okay, in the foot. So the first part of this that I do is the foot's going to come up and in. We're testing the strength of the tibialis anterior, hold. But to put the foot into this position, we have to think in terms of the peroneus longus and brevis has to lengthen to get the foot into this position. All right, so far what we've done is we've tested the tibialis anterior and the peroneus longus and brevis. Okay, so up and in, down and out. So that's half of the X that we're making, if you will. So let's talk about how do we treat the length of the peroneus longus and brevis. So if I bring the foot up and in, remember, this is the position to activate the tibialis anterior, but if the peroneus longus and brevis is too short, we can't get it in that position, so the foot may stay right here. So what I'm going to do is you can't put your hand down here to overpower this muscle. It's an extremely strong muscle group. So I'm going to come in here and tell the patient to take a deep breath in through your nose, breathe out through your mouth, and push at 80% as hard as you can down and to the left. 8, 9, 10, and relax. She does not have that problem. So what she is doing is she's pushing down and out to actually activate the goated tendon organs, and then we're going to do a Hoffman's reflex, and then we're going to go up and in. Now, to test the length of the tibialis anterior, we're going to take the foot down and out, okay? So this is the same test position for the peroneus longus and brevis. All right, so if the tibialis anterior on the left is damaged, this foot's going to go out on the right, but we won't be able to get the foot into the position. So what I'm going to do is stiff arm this, lay my whole body weight on it, and then tell Tony to take a deep breath in, breathe out, bring your foot up and in at 80 to 90% as hard as you can. Deep breath in for me, up and in, 2, 3, 4, 5, 6, 7, 8, 9, 10, relax, and the Hoffman's reflex. So there we are. So in this position, again, the patient is up and in, tibialis anterior, we're testing for the strength. When we go up and in, we're also testing for the length of the peroneus longus and brevis. When we take the foot down and out, we're testing for the strength of the peroneus longus and brevis, and we're testing for the length of the tibialis anterior. So the next muscle group that we want to look at for strength is we actually go right into the peroneus longus and brevis position, okay? So if we stay in this same vein of the anterior tibialis and peroneus longus and brevis, those are agonist-antagonist relationship. If I bring the foot down and out to test for strength, I'm also testing for the length of the tibialis anterior, because if this muscle of the tibialis anterior is too short, I won't be able to get the muscle or the foot into this peroneus longus and brevis position. So I want to do a test on this. Hold for me. Hold. All right, so that's good. Hold for me. I'm pushing up and in. So if this peroneus longus and brevis is abnormal, if it's too weak, then we have to know on the lateral side of the leg, well, actually the peroneus brevis comes on, and right in the small toe here, we actually have a tubercle, and that's where the brevis actually runs through the posterior lateral malleolus. The brevis attaches here, and then the longus actually attaches to the big toe on the plantar aspect, or the great toe on the plantar aspect of the foot. So we come in here, take a deep breath in, breathe out. I want you to bring your foot up and in for me. All right, deep breath in, up and in. Good. And up and in. So we're going to recap. Tibialis anterior, we want to bring the foot up and in. We're going to push down and out to test it. But while we do this at the same time, we're testing for the length of the peroneus longus and brevis. And if the peroneus longus and brevis just happen to be short on this side, we won't be able to get it into that position to test the tibialis anterior. I'm going to go over in just a second how to address that. So again, the tibialis anterior and the peroneus longus and brevis, these are agonist-antagonist relationships. So if I test for the strength of the peroneus longus and brevis, I'm testing for the length of the tibialis anterior. So hold, up and in, okay? And that's the test for the muscle spindle activation of the peroneus longus and brevis. All right, so the next muscle groups that we want to look at for the X, okay, is we want to go down and in, okay? So the down and in, this is going to be our Tom, Dick, and Harry, but you know, the name of it's actually the posterior tibialis, flexor hallucis longus, and flexor digitorum longus for the Tom, Dick, and Harry. I guess the way I said it then was Tom, Harry, and Dick, but nevertheless, the way I explained that. But posterior tibialis is flexor digitorum longus, flexor hallucis longus. They're on the medial side of the leg. They come down into a tendon to the medial malleolus, to the posterior aspect of that, and run under the foot. They basically attach to every bone in the foot. And remember, there's 26 bones in this left foot and 26 bones in the right foot for a total of 52 bones. And you look at the overall number of bones in the whole body, you got 52 of them are just in your foot, all right? This Tom, Dick, and Harry is a major player when it comes to plantar fasciitis. So when this muscle contracts, it actually takes the foot down and in, and the posterior tibialis also maintains the function of the arch of your foot. So if this muscle is hypofunctioning, people become flat-footed or they lose the arch in their foot. So the foot going down and in, if I want to test Tom, Dick, and Harry on this, the posterior tibialis, flexor digitorum longus, and flexor hallucis longus, we're going to bring the foot down and in, and we're going to push it up and out. So hold this for me, hold. All right, now again, when we test this down and in, we're testing Tom, Dick, and Harry, but we're also testing the extensor hallucis longus and the extensor digitorum longus for length. So when we take the foot down and in, okay, if the extensor hallucis longus and extensor digitorum longus is too short, we won't be able to get this foot into that position. So let's go over this, down and in. All right, so we have to know where the muscle group is. It's in the medial part of the leg. And I'm gonna say take a deep breath in, breathe out, bring your foot up and out. Good. All right, slight resistance here, 20% effort by the patient. Deep breath in, breathe out. And again. And then again, if we had the shock wave, we'd run through here, go on the inside of the ankle, bottom of the foot, and that's if a person has plantar fasciitis, that's going to be extremely tough in this area here. So the next thing we're going to do, again, we're in this position. We want to take the foot up and out. When we take the foot up and out, we're testing the extensor hallucis longus and the extensor digitorum longus. At the same time, we're testing the length of Tom, Dick, and Harry, but we're going to push the foot down and in. Hold. Good. So we're going to come in here on the lateral side of the leg. Say, take a deep breath in for me, breathe out, push your foot down and in for me. All right, down and in for me. And again. So as a recap, what we've done here is we brought the foot down and in. When we contract Tom, Dick, and Harry, the muscles, this foot's going to go down and in. The extensor hallucis longus and extensor digitorum longus should be inhibited to bring the foot down and in. To test Tom, Dick, and Harry, we're going to push the foot up and out. And to test the extensor hallucis longus, extensor digitorum longus, to put it in this position, Tom, Dick, and Harry has to be inhibited to get the foot in that position. We're going to push down and in. To test for the muscle spindle strength test of extensor hallucis longus and extensor digitorum longus. All right, so the last part of the X, if you will, and then we'll do a recap. We're going to test the Golgi tendon organ, or the length of the Tom, Dick, and Harry, and the length of the extensor hallucis longus and extensor digitorum longus. So we're going to use the same muscle group here. So if I bring the foot down and in, all right, and if I test for the muscle spindles of Tom, Dick, and Harry, I'm going to push the foot up and out. But as I bring the foot down in this position, I'm also testing the length of the extensor hallucis longus and extensor digitorum longus. So if this muscle group is short, then what I'm going to have the patient do is take a deep breath in, breathe out, and 80 to 90% of their exertion, we're going to push up and out. So let's take a deep breath in for me, breathe out, push up and out. 2, 3, 4, 5, 6, 7, 8, 9, 10, boom. All right, I'm going to do that 3 times. So that's testing the length and treatment of the length of the extensor hallucis longus and extensor digitorum longus. So if I put the foot in the up and out position, okay, I'm testing, if I wanted to test the muscle spindles of the extensor hallucis longus and extensor digitorum longus, I'd push down and in. But when I put it in this position, I'm also testing the Golgi tendon organ length of Tom, Dick, and Harry. So what I would do here, again, in this muscle, you're going to have to get some body leverage here. Slide down toward your feet just a little bit. There you go. So, all right. So I'm going to get in this position, use my body weight, and I would have her take a deep breath in, breathe out, push down and in with your foot at 80 to 90% of your maximum. 8, 9, 10, and relax. Okay? So again, what I want us to understand here is that there's 4 major groups that we have to test in the foot. Those groups together make an X. So when we bring the foot up and in, all right, again, there's 2 sets of muscles that's here. The tibialis anterior, we're testing for strength, and the peroneus longus and peroneus brevis, we're testing for length. If we stay in that same vein, we're in the up and in. If we go down and out, we're testing the exact same muscle groups. But now we're testing the peroneus longus and brevis for strength, all right? And we're testing the tibialis anterior for length. When we bring the foot down and in, we're testing Tom, Dick, and Harry, all right? We're testing Tom, Dick, and Harry for strength, but at the same time, we're testing for the length of the extensor hallucis longus and extensor digitorum longus. So that's down and in. If we take the foot up and out, dealing with the same group of muscles, but we're testing for Tom, Dick, and Harry on length and testing for extensor hallucis longus and extensor digitorum longus in strength. So if it's a little bit confusing, welcome to the real world. But if you can get this down, that these muscle groups make an X, there's 4 major players here that we want to look at. All of these players have a strength test and a length test. So those are the mechanics of the foot. It just didn't sound right. All right, so after the piriformis, we want to look at the hamstring muscles. There's actually 4 muscles here. They are a medial group and a lateral group. We have the semi-membranosus and semi-tendinosus, which is, these are medial muscle groups, and the biceps femoris long head, the biceps femoris short head are our lateral muscle groups. So what we want to do is we want to bring the foot in, internally rotate. We want the foot, the leg here at a 110-degree angle, and hold for me, hold. I'm going to push down. I want you to hold the foot right here, hold. All right, and we're going to turn the foot out, hold. All right. Now, when we do this muscle group, what we're going to do is we have to understand the origin and insertion, the acetabulum right at the gluteal fold. I'm going to take a rapid release, put it right on the gluteal fold, and if we have the foot turned in and it's weak, remember that's the start position. So gluteal fold, and we're going to tell the patient take a deep breath in, breathe out, and push your foot down for me. Push it down and out. All right, so here we go. Rapid release, gluteal fold, deep breath in, breathe out, push your foot down and out. Okay, I'm going to do that 3 times. Down and out for me. All right, and then I'm going to come in to the medial part of the leg. Deep breath in, breathe out, push down and out. Push down and out for me. Just go right down the leg to the knee. And down and out. All right, so we have the foot turned out, hold, and it's weak. Again, we're going to start at the acetabulum. Deep breath in for me. Rapid release, deep breath in, push down. Turn your foot in. Turn your foot in for me. Turn it in. Deep breath in for me. Breathe out. Push down and turn in. Turn your foot in. There we go. All right. Deep breath. I'm going again. When I have a patient here, she doesn't need to do everything perfect, because in the clinic they're not going to do things perfect. So just realize that you may have to repeat things more than one time. So we come in here, lateral aspect of the leg. Deep breath in. Breathe out. Push your foot down and in. Perfect. Down and in. And down and in for me. All right, so that's going to be our hamstring muscles. That's how we test for the strength, and now we actually treat the muscle spindles to send a neurological reflex into the spinal cord, ipsilateral cerebellum, and contralateral brain to neurologically strengthen this muscle group. All right, so now we're going to go supine, and there's our muscle groups that we want to test here in the supine position. So when the patient is supine, the first muscle that I want to test is going to be the hamstrings for length. All right, so we take it, we're going to stiff leg it here, and that's really good. All right. All right. So now there's 2 different mechanisms here, just like with the rectus femoris. You've got a hip flexor and a knee flexor, and with our hamstrings, we want to deal with the superior and the, in the anatomical position, the inferior aspect and the superior aspect of the hamstring. So when we do this procedure, the first one that we're going to do is I just want her to take her heel, and she's going to bring it into this position here, just kind of like you're kicking your butt, okay? So we're going to come in here. She's just going to bend her knee, deep breath in, breathe out, and pull your foot down only. 2, 4, 5, 6, 8, 9, 10, and relax. And I would do that 3 times. Now, and then we also have to get to the superior aspect of the glute max, and this time we want to just pretend that this is one entire unit right here, and you're going to bring the whole leg down like that, okay? So again, rapid release, come in here on the superior aspect of the hamstring, deep breath in for me, and pull down. 1, 4, 5, 6, 7, 8, 9, 10, good. Right there. So that would be looking at the length test for the hamstring muscle groups. And remember, there's 2 positions we have to put the leg in to optimize the recovery of a short hamstring. All right, so the next set of muscles that we're going to do while we're supine is we're going to be testing for the muscle spindle activation. Is the muscle strong or is it weak? And there's a certain flow that I do in my clinic when patients come in with back and hip and knee problems. So hopefully this flow chart that we're doing here is going to help you out tremendously. So could I get get you to slide over toward me just a little bit, okay? So this first muscle that we're going to test, and remember we've got to do the 90-degree angle, so let's hold this foot up for me. And when we do the test, we got to get 90 degrees here with the actual lever that we're using. We're going to do the rectus femoris. Remember that rectus femoris is it's a hip flexor and a knee extensor. So we got to check both ends of that. So we're going to take the leg at a 45-degree angle, and then we're going to hold. I'm testing the right leg. I'm actually going to hold down on the ASIS of the left side. So let's hold this up for me, 45-degree angle, and hold. Okay, and so that needs to be strengthened. We're going to turn the foot out. This is testing the iliacus. Hold. All right, and then this is turning the foot out at a 45-degree angle. So if we go up 30 degrees and come out 30 degrees with the foot turned out at a 45-degree angle, we're actually testing the psoas muscle. Hold. All right, and so all of those actually need to be addressed. So, so we want to actually test those three muscles, and then we're going to go right in and treat what we find. All right, so what we're going to do now is we're going to turn the patient prone, and then we're going to actually test the muscle spindles for strength. So the first muscle that we want to test here is we're going to bring the foot in extension, and we're going to rotate. We're going to turn the foot in, and we're going to test the glute max. So just hold that position right there for me. Hold that up. I need you to hold it up like that. All right, hold for me. Hold. All right, and that muscle is weak, okay? So what we would do, I'm going to show you two different angles here to actually treat this. So we want to turn this side up for me. You can go ahead, lay on your side with this side up, this side right here up. This we're treating this. All right, the easiest way to do this, there's a lot of different ways to treat the glute max, but what I'm going to do is take a rapid release and put it right here on the glute max. How did we test this? We had the foot in this position, in here, and as the patient, remember, just use your imagination, she's laying on her belly, prone, and this is the position that I actually tested her. So she's going to bring her foot up, okay? I'm sorry, you're going to bring her knee up into this position here, toward her head, and that's exactly the way I explained it to the patient. So rapid release here, deep breath in for me, breathe out, bring your knee towards your head for me. I'm going to try to get out of the way of all the way up, there we go. So I'll do my best to stay out of the way of the camera, deep breath in, breathe out, and go, good deal. So again, rapid release to hit these muscle fibers in the glute max. Okay, so now we're actually going to segue from testing muscle strength to actually muscle length. So let's just recap for just a second. When we're treating for muscle strength, we're testing the muscle spindles. The patient is going to exert about 20% force with slight resistance from the doctor. And when we're dealing with the Golgi tendon organs, the patient is going to exert 80 to 90% force with minimal movement from the patient. The doctor is going to restrict the movement, and we're also going to be doing the Hoffman's reflex at the end of the procedure. So the muscle spindle activation is 6 seconds. Golgi tendon organ activation is 10 seconds. So the patient is prone. So what we're going to do is we're going to move, all we have to do here is take the foot and we're going to push it toward their butt, okay? So we look here and you can see the rectus femoris on this on her right side is short. For optimal, the optimal distance here should be about 2 inches. But I mean, if both heels were at this position, I wouldn't, can you tell the difference in that? The camera can see the difference in that, right? Okay, so what we have here is we have a rectus femoris that's short on on her right side. So what we do here to treat this is I want you to lay on your side with this side up for me. All right, so this, all right, so right here. Now, so what we're going to do with the patient is the patient's actually going to kick against my leg here. Then she's going to exert 80 to 90% force, not going to allow her to move the leg. Then we're going to do a Hoffman's reflex at the end. So rectus femoris, let's take a deep breath in, breathe out, kick your leg toward me. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. All right. Let's do that again. Deep breath in for me, breathe out, and kick. Now in the clinic, I would actually be using a rapid release to do this. 6, 7, 8, 9, 10. And one more time, deep breath in for me, breathe out, and get 1, 3, 4, 5, 6, 7, 8, 9, 10. All right, let's lay on your belly for me. So test, treat, and retest. So what we're going to do is, so here, and there we are. And I think even the camera can see that. So the patient, again, is in the prone position. The first, we're going to be testing for the length of the muscle groups, and we came in and we said here, rectus femoris. Ideally, we would want to see the heels 2 inches from the hip. All right, we've gone over how to treat that. The piriformis, the legs here need to be at least 45 degrees. All right, the next thing we're going to do is test the glute medius and minimus. We're going to bring the foot in. All right, now we can see here that that's a problem because you can see how our hips come off the table right there. All right, hopefully this one will be good. And it's not as bad, but it's not as good as this one right here, or bad that way. You can see how the hips are coming off because what should happen is the hips should just rotate in the joint. We shouldn't be pulling the hip off the table. And I will tell you, for me and from my standpoint, this is one of the harder muscles to actually correct from a Golgi tendon organ standpoint. So what we want to do is we're going to take a deep breath in, we're going to breathe out, and I want you to rotate the foot out in this position. Now in the clinic, the way I do this is I actually stand on this side of the table with the rapid release in the hip area right on the glute medius and minimus. But for the camera's sake, I'm going to stand on this side and just assume that I have a rapid release here, because you can see how that's going to negatively impact my back bending over a patient like that multiple times throughout the day. So I want you to take a deep breath in for me, breathe out, and rotate your foot out for me like that. Deep breath in, breathe out, and go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. All right, and let's take a deep breath in for me again. Deep breath in and out. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And again for me, deep breath in, breathe out, and push out for me. 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay. All right, let's see if we, and again, just telling you that this is the hardest muscle for me to actually fix from a Golgi tendon organ standpoint in the clinic. Let's see what happens here. And you can see how she's still coming off the table like that. All right. In the clinic, this is exactly how I would do it. I'm on the same side as the bad hip of the glute medius and minimus, and she needs a little help here. So let's take a deep breath in, breathe out, rotate your foot out for me. 2, 3. And relax. Deep breath in for me, breathe out, and go. 8. All right, and one more time. Deep breath in for me, breathe out, and go. 2, 3, 4, 5, 6, 7, 8, 9, 10. And it's been a while since I've used my thumb so much, and I can tell you, I wouldn't want to do that every day with every patient. So that would be our glute medius and minimus testing for the Golgi tendon organ length test. Turned in, and as we bring the foot down, we want to turn the foot up toward the ceiling, or you can say bring your heel to your other heel, but the foot has to go up when we do this. All right, so we come in here at the tensor fascia lata, And we're just going to go right down this band here. And now, what's important when you're treating this area, what's vitally important is the closer you get to the knee, the more pain the patient is going to experience, because this is the tendon down here, which means you're not getting adequate blood flow, and so it can be painful, especially if you're using a rapid release. So when we're doing the hip stuff, the only time I ever use my thumb is for illustrations like this. In the clinic, I use a rapid release. So let's take a deep breath in for me. Breathe out, pull down, and turn your toe up for me. All right. Deep breath in, pull down just a little bit harder. Deep breath in, breathe out, and go. 2, 3, 4, 5, 6. And again for me. 2, 3, 4, 6. And again. Good. All right. So when we look at the glute medius and minimus, we can come right down below the iliac crest. Below that. Now with the minimus, if you look at the origin insertion, the foot needs to be up and the hip is flexed slightly. So when we come into this position, we want to take a deep breath in, breathe out, and then go heel to heel right here. Deep breath in for me, breathe out, and go. 3, 4, 5, 6, and again, this is almost always a rapid release for me right here. Deep breath in, breathe out, and go. So again, the glute minimus, when it's weak, we've got to have the foot up into this position and then come back down. It just has to do again with origin insertion. Glute medius. Glute medius, we're in this position. We're going to take a deep breath in, breathe out, and go straight down that foot to the other foot. Deep breath in for me, breathe out, and go. Deep breath in for me, breathe out, and go. And again for me. All right, so in this illustration, what we've actually talked about is so the patient will sit on the end of the table, and then we'll lay back for me. And when we lay back, what we're going to do is we're going to be bringing this right knee to their chest, but what we're going to be doing is testing this left psoas. So what we'll do is in this position here, and if the psoas is short, then this knee will come off the table at some level. All right, let's go to this side here just to see what happens. And it's all good. But what I want us to do is if you could go up and lean, go to this side of the table. All right, so what we're going to do with this is if the patient is short in that position, let's go ahead and drop that down for me. All right, so what we're going to do is trap the leg here with my leg. We're going to come in here on the psoas. Remember, we're going to take the ASIS and the ASIS and the thenar here. We're on the psoas. And I want you to take a deep breath in for me and then pick your knee up and kick it up toward the ceiling. 2, 3, 4, 5, 6, 7, 8, 9, 10. Good. All right, let's do that again. Deep breath in for me, breathe out, push up. And again, that's good. All right, so I don't want to push her in that position because simply she does not have, that's not an issue that she has. So the next thing that we're going to do, kind of center on the table right here for me. All right, and then we want to test the length of the adductors of the leg. So we want to come out, and as long as they're at 45 degrees or greater, they're fine. There, drop that over there. All right, let's just drop that leg down right there. The reason we want to drop that leg down is because when we do the Hoffman's test on the adductors to see if they're short or not, when we actually start to do the Hoffman's test, we don't drop the leg down on the side, it's going to spin her around. So we're just going to do one of these. I want you to take a deep breath in, breathe out, bring your leg in like that for me. All right. So right here on their pants, there's a seam right here, and that's exactly where you want to be. So let's take a deep breath in, breathe out, and bring your leg in. 2, 4, 5, 7, 8, 9, 10. Relax. And again, if you don't have this leg over the table, as soon as you do the Hoffman's reflex, you're going to swing the patient off the table, hence no Hoffman's reflex. So in this test, we tested the psoas muscle, we did a test treatment, and of course you want to retest if there was a positive